So if you are moving my humerus, okay, let me just bring diagrams so that you will understand. Then let's talk about the concave rule. The concave rule is the one at the bottom. You see that the red arrow is now on the tibia, which is concave shape. Concave rule states that whenever a concave bone is moving on a convex surface, the movement that is carried out will be in the same direction as the movement that the patient is going to gain. Just know that concave, they are the same. Convex is opposite. It will become clearer to you with this diagram now. Just bear in mind that concave, everything is in the same direction. For convex, it is opposite. Now look at this diagram, guys. Look at this diagram here. In this diagram, let's talk about the shoulder first. You know, shoulder is going in abduction, isn't it? If a therapist is mobilizing a patient in abduction, that is the movement being carried out. Are you with me? That's the movement being carried out. You know, convex rule says that when you move a convex bone on concave surface, movement being carried out and the movement gain will be opposite. So the movement we are carrying out here is abduction. And what's the opposite of abduction? Adduction. ABC deduction. So whenever you continue to mobilize like that, you are stretching the capsule in the joint in a way that when you finish your mobilization, you will notice that patient has recorded increase in ABC deduction instead of abduction. All right, that is convex rule. But what about concave rule? Look at the diagram at the bottom here. Can you see the diagram at the bottom? It's similar to when a patient sits on a chair, eye sitting. Like when a patient is doing eye sitting, when the feet is not making contact with the floor, and you ask the patient to flex the knee and extend it, flex it and extend it. Or flex the knee and bring it back, flex the knee and bring it back, flex the knee. And what movement will the patient gain at the end of the day? You have to apply the concave rule. Because in this situation, the tibia is the one moving backward and the shape is concave. And concave rule states that whenever a concave surface is moved on convex, both the gliding and the movement will be in the same direction. So it means that if you set a patient on eye sitting and you are moving the tibia backward, and movement backward is called what? Flexion. If you do that 100 times or 50 times, by the time you finish, the movement that the patient will still gain will still be flexion. Because when you move concave, both movement and gliding will be in the same direction. But when you move a convex surface, both movement and gliding will be in opposite direction. Don't worry if you are not very clear. I know it takes time. By the time you go over it again, and then we'll still be making reference as we go on, you will have a better understanding. Have a look at this diagram. This one might explain it a little bit better. This one might explain the concept a little bit better. Now look at the one on the left-hand side, on your left-hand side. I was gliding. I was doing a anterior-posterior glide. Abi, that's anterior-posterior glide because I'm pushing in the posterior direction, isn't it? On the head of humerus. What is the shape of the head of humerus, guy? Convex. You know it is convex. So, and I'm pushing posteriorly. What movement normally goes in posterior direction in the shoulder? That is extension, isn't it? So normally, you will just think that patient will stand up and the extension would have increased. But if you continue with that glide, at the end of the day, if your patient stand and you measure the range of motion, you see that it's flexion that have increased, not extension. All right? That is what Katembon is saying, that if you move convex surface on concave, the movement and the gliding will be in opposite direction. But look at the diagram on the right-hand side. Okay, this is mobilizing the knee joints. All right? You see that my hand or the hand of the therapist is on the tibia, and the tibia is concave. Isn't it? The tibia is concave. And the hand is pushing the tibia in a forward direction and in a posterior anterior direction, in anterior glide. This is anterior glide of the tibia. And when you move tibia anteriorly, ordinarily in the knee joint, that is extension. You are looking for extension of the knee. Here, because the tibia that we are moving is a concave bone, it's concave rule that will apply. And concave rule states that when you move concave surface on convex, both the movement and the glide will be in the same direction. So if I do this one for 5 minutes, by the time the patient stand up, the patient will gain extension because I'm pushing in the direction of extension and I'm pushing a concave surface. I'm sure some of us would have catched the understanding of this converse concave rule phenomenon. By the time we have opportunity to treat peripheral mobilization, it will become crystal clear. All right. Now, another law we are building up to the main work that we have to do. Another law which I want us to go through very quickly is what is called Fred law. This law has a lot of bearing in spinal mobilization. And there is first law, there's second law, there's third law. What does Fred's first law state? Fred's first law stated that when a spine is in neutral position, side bending to the spine in one direction will result in rotation to the opposite side. I think it's a common sense. Let's say your patient is lying down or your patient is seated and is seated in an upright direction. It's not tilted to one side. It's not tilted anteriorly or posteriorly. You now ask the patient to do left side bending of the trunk. As the patient is doing left side bending of the trunk, where would the face be facing? The face will be facing the right side. You can try it where you are seated. Sit in a neutral position. Now do left side bending. Then look at the position of your eyes. Is your eyes still going in the left? No, your eyes will now be pointing in the right. So as you do left side bending, the rotation of the spine will go in opposite direction. This is first law of Fred's. Why is this very important for us to know? If you want to mobilize your patient and you ask patient to lie prone, make sure they are neutral. If they are in neutral line, they are not tilted to one side before you start mobilization. If they are in neutral position, as you are doing the mobilization, to increase rotation, if you look at this diagram now, and this law is saying that when you side bend to the left, you will gain rotation to the right. Don't forget that too, because I'll still repeat it again. Any manipulation or mobilization that you do that will result into left side bending of the spine will produce right side rotation. Or any mobilization or manipulation you do that will cause right side rotation will produce left side bending. So I want you to please take note of that. I want you to take note of that because we are still going to come back to it very shortly in our explanation. This is Fred's first law. The Fred's second law is also very similar, but it's different. In Fred's second law, there is no neutral spine. The patient is not starting with a neutral spine. Look at the diagram you have below here, not the top one, the one you have below. Somebody is already tilted into extension, all right? Or where you are seated, just move yourself into extension and then bend to the left. As you bend to the left in that extension, your rotation will also go to the left. As you bend to the right in that extension, your rotation will also go to the right. Or if you put yourself in flexion and you now side bend to the right, your rotation will still go to the right. So Fred's second law is saying that in a non-neutral position, that is either flexion or extension, side bending of the spine to one direction will also produce rotation on the same side. Okay? This one does not hold much applicability in manual therapy like the first law. I want you to please remember that first law, that any mobilization or manipulation you are doing on the spine that is causing rotation on the right will produce left side flexion. Or what is causing left side flexion will produce right rotation at the same segment. We'll come back to that. And then the third law, there's a third law. The Fred's third law states that increasing the range of motion in one plane will result in modification of motion in other two planes. And I think this is very easy to understand. Consider a patient that is having scoliosis, for example. You know, like we have in this diagram. Scoliosis is not a lumbar postural alignment. So like in this patient now, if you look at the thoracic, the scapular area, there is too much of movement, isn't it? To the right. There's too much of convexity to the right. But there is a segment above and below that area. All right? In manual therapy assessment and treatment, we are not worried only about the area of lesion or area of complaint of the patient. We are also worried about the upper part and the lower part. And that is what this law is trying to tell us. Anytime more movement has taken place in one segment, the segment above and below it, they will suffer lack of movement. It's a compensatory mechanism, like we have in scoliosis here. If there's too much movement around the scapular area, then the area above the scapula and the area below the scapula, they will suffer hypomobility. So when you have a patient presented like that, you will know the work that you have to do. All right? As you have a patient having hypermobility in one direction of the spine, you know there will be compensatory hypomobility in the region above and the region below. This is a principle that is very useful when you are treating spinal condition. This is Fred's third law. So please let us bear all this in mind. I'm going to run through all this basic before we now go to specific parts of the body. Now, the next aspect I want us to look at is specific techniques of mobilization to enhance spinal range of motion. I'm not talking about manipulation yet. I'm talking about mobilization. What are the specific techniques of mobilization that we can use to achieve flexion in the spine, extension in the spine, side flexion in the spine, rotation in the spine? You know, the focus of our presentation is the spine. All right? If you have a patient that comes to your clinic and the diagnosis says L4, L5 spondylosis, and this patient is already having reduced range of motion in all directions, what technique will you do to promote flexion, to promote extension, to promote rotation, to promote side flexion? That's what we want to look at. I hope you are with me. Now let's go to the next slide. Now, if you look at this slide,